Thanks, Karen. Good afternoon, everyone. I'm Twyla Dillian, and we are so glad that you could join us today to learn more about our work, building community capacity to address racial disparity in maternal mortality and morbidity. Today, Dr. Hartman will cover the epidemiological background on maternal mortality and morbidity in the nation, New York State, and Rochester, New York, followed by Danielle Jones, who will cover the community-focused approach that was used in this work. And finally, I'll wrap up with our results and next steps. We will leave some time at the end for any questions that you may have. First, Dr. Hartman.
Thank you, Twyla, and thank you for those introductions. And we really are honored to be here sharing our work with you today from little old Rochester, New York. So if you want to go ahead and advance it. So many of you are familiar with some of this content, but it's important for us to contextualize things. So we know probably that maternal mortality is defined as early or late within 40 days of delivery or late within 1 year of a delivery. And then we talk about this mortality in terms of pregnancy or non-pregnancy related, so a complication of pregnancy itself versus exacerbation or deterioration of an existing condition. And then maternal mortality is often reported in a ratio of deaths per 100,000 live births within a state, region, country. In the US, our target would certainly to be 0, and 700 maternal deaths per year in the US is a low absolute number, but the fact that it should be 0 is what we're really focused on. So if we could advance to the next slide. And then the disturbing thing too is that we know that in the 1800s and early 1900s, our rates were much higher, and they've actually been decreasing up until the 1980s or 1990s. And then sometime around 2000 or slightly before, we started to see this bump in maternal mortality that has continued to increase over time. So again, small absolute numbers, but the fact that it's increasing is the disturbing part. And also the fact that when we really look at the birth statistics or hospital records, probably 50% of these were preventable. And then next slide. And so we have some, it's hard to measure this, and it depends on which definitions we use, but it's pretty clear when you look at the data from different angles that there is some disturbing data here. And so the orange line in this graph is New York City. The green is New York State, and then we've got the rest of the state in the United States, which kind of match each other. But what we can see is that in New York City, the numbers for maternal mortality have actually improved a bit since a spike in the early 2000s. Whereas in the rest of the country and even the rest of New York State, we've seen this disturbing increase that may have leveled off, but obviously we seem to be doing worse than New York City in some ways. And next slide. And then again, what's more disturbing is that there is really this huge racial disparity. And for Black women in New York State, the numbers look the highest, especially compared to white women in New York State or in the United States in general. And that in New York State, we actually looked worse for Black women than in the rest of the United States. So the causes of maternal death, and this is New York State data, it has shifted a bit. So in 2006 to 2008, we were really looking at hemorrhage as the top cause, and then hypertension and some other non-cardiovascular causes. But it shifted a bit now where hemorrhage is still very significant. The venous thromboembolism and infection seem to have become more significant, statistically more significant drivers. And something that some of our New York State people have really focused on is severe maternal morbidity. And this is because the numbers are so low for mortality that we're really trying to look at sort of what's leading to that mortality, but also severe maternal morbidity in other ways may be a better surrogate and something that we should look at when we try to look at preventable causes. So we've been focused a lot more on this recently. Severe maternal morbidity is defined by the CDC as 18 specific conditions, which I won't go into in any detail, but just to say that, they range from cardiovascular and thromboembolic kinds of causes to more infectious or hemorrhage related to transfusion. So, and what is also significant about this is it is 50 to 100 times more common than maternal death, and the incidence is estimated to be about 1.5% of all pregnancies in New York State. So severe maternal morbidity in the US has been increasing, and we have some reasonable data. It's almost, I won't say easier, but in some ways it is probably easier to assess this than to assess the cause of death. And so from 1993 to 2014, these numbers have been increasing, but they've been increasing more in Black women than in white women. The major driver seems to be increasing rates of postpartum hemorrhage due to uterine atony, but there are some potential other causes as well. Next slide. And then what we see here, when we specifically look at our New York State data, we found that the incidence for Black women is really almost twice that of white women for severe morbidity. This in some ways parallels the mortality data, but also significant that white, Hispanic or non-Hispanic women don't seem to have, they seem to be pretty similar in incidence as opposed to Black women. And so what we can conclude from what we have New York State data so far is that hemorrhage with transfusion really seems to be the top driver. And this is definitely true worldwide, but Black women in general seem to have a higher rate of severe maternal morbidity. And that when we control for things like smoking, living in certain zip codes and other kinds of social factors, it still doesn't explain those differences. Next slide. And then, so we talk about social determinants of health a lot as underlying these medical causes, and that really we won't get to the bottom of this if we don't look at the social determinants of health. But what's interesting is when you look at the New York State data, especially, that when we look at things like gaps in health coverage, lack of coordinated care, inadequate social services, lack of transportation or housing, that there still is a racial disparity when you try to control for all of these things. And so what we really come down to is that structural or systemic racism really has to be at the core of this, and we really have to address that or we won't get to the bottom of this. And so we're presenting our project in Rochester, which really focuses on addressing some of those issues in what we think is a novel way. So with that point, I would like to turn it over to my esteemed colleague, Daniel Jones.